Hello everyone, welcome back. Today I'll be covering journal number 1 is my notes regarding the sequential correction versus conventional correction for severe and rigid kyphoscoliosis, a retrospective case control study. Journal by Wenbi Hua et al. Published on 28 September 2023. Now let's get started. Objective of the study. Conventional correction techniques were challenging and of high risk of neurological complications for the severe and rigid kyphoscoliosis. A new technical method developed by the author is named sequential correction, was used to treat severe and rigid kyphoscoliosis. The present study was to compare the clinical outcomes of sequential correction versus conventional correction for the treatment of severe and rigid kyphoscoliosis. An introduction. A severe and rigid kyphoscoliosis in adults is defined as a deformity with major curve corpse angle more or same 90 degree and flexibility less or all the same 30%. Correction of severe and rigid spinal deformity is difficult, with high risk of neurological complication. Conventional correction techniques combined with 3-column osteotomies, such as pedicle subtraction osteotomy (PSO), grade 4 spinal osteotomy, bone disc bone osteotomy (BDBO), vertebral column resection (VCR), multilevel VCR were used commonly. Circumferential vertebral column resection and posterior vertebral column resection (PVCR) have been developed to correct severe and rigid spinal deformity. Even though conventional correction techniques combined with 3-column osteotomies were proved to be of excellent clinical outcomes in the previous studies, only 2 long rods are used to correct the severe deformities during conventional correction procedures, maintaining the coronal and sagittal alignment. Therefore, conventional correction was still challenging and had high risk of neurological complication. The purpose of the study is to 1. Describe conventional correction and sequential correction. 2. Evaluate the efficacy and feasibility of both methods. 3. Compare the clinical outcomes of both methods. Surgical technique. All surgical corrections were performed via a posterior approach. All procedures were performed under multimodality intraoperative neurophysiological monitoring, including motor evoked potential and somatosensory evoked potential. For a conventional correction technique, the pedicle screw were implanted, facetectomy and costotransversectomy were done. Grade 4 spinal osteotomy or posterior vertebral column resection (PVCR) were performed at the apical vertebrae, and the osteotomy sites were fixed with 2 short segmental rods to maintain the stability of the spine. Then a long rod are inserted at the convex side from upper instrumented vertebrae UIV to lower instrumented vertebra LIV, and the rod cantilever technique was used directly to close the osteotomy sites, maintaining the coronal and sagittal balance or alignment. Then the short segmental rod was removed and another long rod was inserted at the concave side from upper instrumented vertebra to lower instrumented vertebra to achieve a global balance. This figure shows a conventional correction steps for severe and rigid kyphoscoliosis. You can see in A, there's a screw placement, vasectomy, grade 4 spinal osteotomy, or posterior vertebral column resection were performed at the apical vertebrae, with the osteotomy sites maintained with short segmental instrumentation, as illustrated. B. Correction performed via the rod cantilever technique with 2 long rods. B. Sequential correction technique. The procedures of sequential correction technique were divided into 6 steps: screw placement and vasectomy, asymmetrical 3-column osteotomy at the apical vertebrae, major curve correction at the apical vertebrae, correction maintained with short segmental instrumentation, further correction via the rod cantilever technique, and integration with appropriate application of long rods. Grade 4 spinal osteotomy or posterior vertebral resection were performed at the apical vertebra. The osteotomy sites were fixed with 2 short segmental rods to maintain the stability of the spine. Then, the gap between the osteotomy sites was closed step by step, partially correcting the scoliosis and kyphosis. Afterward, a short segmental rod at the concave side was reserved to maintain the correction at the apical vertebrae. The other short segmental rod at the convex side was removed. Then, a long rod was inserted at the convex side from upper instrumented vertebrae to lower instrumented vertebrae, and the rod cantilever technique used. Another long rod was inserted at the concave side from upper instrumented vertebrae to lower instrumented vertebrae to achieve a global balance. This figure shows the sequential correction step for severe and rigid kyphoscoliosis. A shows a screw placement, vasectomy, grade 4 spinal osteotomy or PVCR, and major curve correction at the apical vertebrae. B and C shows a correction maintained with short segmental instrumentation, and further correction via the rod cantilever technique. D. There is an integration with appropriate application of long rods. Findings and discussion. It was found that the clinical outcomes of sequential correction versus conventional correction for severe and rigid kyphoscoliosis had no significant differences. For patients with severe and rigid kyphoscoliosis, surgical treatment is recommended to improve the pulmonary function and increase the life expectancy. Surgical correction of severe and rigid kyphoscoliosis is challenging and associated with a high risk of neurological injury. Anterior and posterior vertebral column resection is a choice for the treatment of severe and rigid kyphoscoliosis. But posterior-only approach is preferable with the advancement of pedicle screw system. This figure shows an X-ray of AP and lateral view of the spine. It shows a coronal major curve angle and kyphotic angle were at 141 degree and 98 degree through lateral view. For C and D, it shows the preoperative back appearance. This next figure shows the postoperative X-ray. It shows there's a correction from AP view to 31 degree and lateral view to 29 degree. And this is the postoperative appearance. The author emphasized that the major superiority of sequential correction is to make the complex deformity correction as a step-by-step procedures, which could be performed more safely. In conventional correction technique, only 2 long rods are used to correct the deformity and maintain global coronal balance and sagittal alignment. During the sequential correction, the major curve was partially corrected via the apical vertebrae osteotomy and fixed with one segmental rod. The short segmental rod is helpful to prevent the displacement of the osteotomy site, maintaining the correction at the apical vertebrae and disperse the stretching force on the apical vertebrae area. One long rod on the convex side was used to correct the major curve via the rod cantilever technique. Then another long rod was used only responsible for controlling a global alignment. The spine can be stabilized after each surgical step, and the final biomechanical property is also superior compared to the traditional two-rod instrumentation. Conclusion. Author concluded that sequential correction is an excellent and safe treatment for severe and rigid kyphoscoliosis in adults, with similar outcome with conventional correction. The total complication rate of the patients underwent sequential correction was slightly lower than conventional correction. Yay! We have reached to the end of this video. See you in the next one. Take care and bye.